Disorders. 1. Question. How does the clinical diagnosis of epilepsy differ from a single seizure event? Answer. Epilepsy is diagnosed after at least 2 unprovoked seizures that are unrelated to fever or acute cerebral insult. Why? A single seizure can be caused by transient factors like high fever or metabolic imbalance, whereas epilepsy indicates a chronic tendency for recurrent electrical discharges. 2. Question. A 3-year-old child has 2 generalized seizures within 12 hours during a fever. Is this a simple or complex febrile seizure? Answer. This is a complex febrile seizure. Why? Simple febrile seizures must be a single attack within a 24-hour period. Multiple attacks within that time frame categorize the event as complex. 3. Question. Why is a child who experienced their first febrile seizure at 7 months old at high risk for occurrence? Answer. Young age. Less than 9 months. At the first episode is a specific risk factor for occurrence. Why? The immature brain is more susceptible to temperature-related electrical instability, and a first episode at a very young age suggests a lower threshold for such events. 4. Question. Why might a patient with a generalized tonic-clonic seizure appear blue, cyanotic? Answer. Cyanosis can occur due to irregular respiration and hypoxia. Why? During the tonic, stiffening phase, respiratory muscles may contract and restrict normal breathing, leading to a temporary drop in oxygen levels. 5. Question. Why are protective helmets often prescribed for children with atonic seizures? Answer. To prevent head injury from drop attacks. Why? Atonic seizures involve a sudden loss of muscle tone, causing the child to fall abruptly to the ground without warning, making the head highly vulnerable to impact. 6. Question. What distinguishes a focal impaired awareness seizure from a focal aware seizure? Answer. The state of consciousness. In focal impaired awareness, the child is not aware of themselves during the attack. Why? Focal aware seizures only affect a part of the brain without impairing consciousness, whereas focal impaired awareness involves deeper or more widespread disruption that alters awareness and often includes automatisms like lip smacking. 7. Question. Why are subtle seizures particularly difficult to diagnose in neonates? Answer. They manifest as small movements like eye blinking, tongue thrusting, or rowing of limbs. Why? These can be easily mistaken for normal neonatal movements or non-paroxysmal repetitive behaviors. 8. Question. Why is status epilepticus considered a medical emergency? Answer. It produces life-threatening disturbances in physiologic function and has a mortality rate of approximately 5%. Why? Seizures lasting longer than 5 minutes, or repeated seizures without regaining consciousness, can lead to permanent brain damage or systemic failure. 9. Question. Why is a lumbar puncture, LP, sometimes necessary in seizure investigations? Answer. To detect low CSF glucose, metabolic disorders, or chronic infections. Why? LP identifies underlying pathologies, like bacterial meningitis, that could be triggering the seizures rather than primary epilepsy. 10. Question. Why do clinicians start epilepsy pharmacotherapy with a single drug at a low dose? Answer. To maximize seizure control while minimizing drug toxicity and adverse effects. Why? Most anti-epileptic drugs have significant side effects. A gradual start low, go slow approach helps identify the lowest effective maintenance dose for the individual. Part 2. Cerebral Palsy, CP. 11. Question. Why is cerebral palsy described as a static or non-progressive encephalopathy? Answer. Because the lesion to the brain is permanent and does not worsen over time. Why? While the physical manifestations, like muscle contractures, may change as the child grows, the original brain damage itself does not spread or increase. 12. Question. Why is kernicterus, severe jaundice, listed as a postnatal risk factor for CP? Answer. High levels of bilirubin act as a toxin to the developing brain. Why? Bilirubin can cross the blood-brain barrier in neonates, damaging the basal ganglia and specifically leading to dyskinetic CP. 13. Question. Why is hand preference in the first year of life considered a red flag for CP? Answer. It is a late infancy pointer to potential motor impairment on the opposite side of the body. Why? Infants normally develop hand preference much later. Early preference suggests the other hand is weak or affected by hypotonia. 14. Question. Why is spastic diplegia highly associated with preterm infants? Answer. Preterms have a high incidence of intraventricular hemorrhage, IVH, and periventricular leukomalacia. Why? These specific types of brain bleeds and white matter injuries commonly occur in premature births and affect the motor pathways primarily responsible for the lower limbs. 15. Question: why do children with spastic diplegia often exhibit a scissoring gait? Answer: due to hypotonia and brisk reflexes in the lower limbs. Why? Overactive muscles cause the legs to pull together and cross over each other, like scissors, when the child attempts to walk or crawl. 16. Question: why is spastic quadriparesis considered the most severe topographic form of CP? Answer: it involves weakness in all forelimbs, the neck, and trunk muscles. Why? It is associated with the highest rates of severe mental retardation, common and life-threatening complications like recurrent pneumonia due to swallowing difficulties. 17. Question: why does dyskinetic CP often involve tongue thrusting and athetosis? Answer: because it results from damage to the brain areas, often from bilirubin, that control involuntary movement. Why? Athetosis, slow, writhing movements, and tongue thrusting are manifestations of the brain's inability to regulate muscle tone and coordinate smooth motor patterns. 18. Question: why do children with ataxic CP struggle with writing and fine motor skills? Answer: ataxic CP results from damage to the cerebellum. Why? The cerebellum is responsible for balance, depth perception, and coordination. Damage here makes precise, steady movements like writing very difficult. 19. Question: why is a multidisciplinary approach mandatory for CP management? Answer: because CP involves associated deficits beyond just movement, such as vision, hearing, speech, and intellectual disabilities. Why? A single doctor cannot address the combined needs for physical therapy, surgery, special education, and sensory support. Specialists like speech therapists and orthopedic surgeons must work together. 20. Question: why are skull X-rays and CT scans used in the diagnosis of CP? Answer: to look for intracranial calcification, cerebral atrophy, or dysgenesis. Why? While the diagnosis is clinical, neuroimaging helps identify the specific nature and timing of the brain injury, which helps in classification and prognosis.